I am Dr. Supratim Sen. I'm a senior consultant pediatric cardiologist. So, CHD or congenital heart defects are defects which a child is born with. And the heart defects are the commonest congenital anomaly that we see in children. Congenital heart defects can be of various types. You can have holes in the heart, you can have a blocked valve, you can have a leaking valve, you can have a small vessel size of the vessels which supply blood to the heart, or you can have a combination of these. And depending on which defects you have, you will have different symptoms. So CHDs are seen in about 1% of the general population. It is said that for every 1,000 live births, there will be 8 to 10 children born with a CHD. Now, in India, that translates to about 250,000 babies being born with a CHD every year. And it is estimated that about one third to one fourth of these babies will have a critical CHD, which will require some sort of a surgery or an intervention within the first year of life itself. It has been seen that if one of the siblings has CHD, there is a 4% increased risk of another sibling also having a CHD. This does not necessarily have to be the same CHD. It could be any other heart defect also. And generally, that is the reason that if one sibling has a CHD, whenever the parents plan a subsequent pregnancy, we do recommend that they get a fetal echo done between 18 to 20 weeks of gestation. So there are a wide variety of symptoms. The commonest ones would be poor weight gain, fast breathing. When these babies feed, there is a feeding difficulty. So they have what we call suck, rest, suck cycle. So they feed a little bit, they get tired, they sleep off, then they again feel hungry, they again start feeding. They have increased sweating in their foreheads. They can have multiple respiratory infections within the first year of life. Some congenital heart defects have cyanosis, meaning these babies will turn blue on crying. Older children can get tired very easily if they have a congenital heart defect. Some children can even lose consciousness. So, a wide variety of symptoms which will help us narrow down on what is the diagnosis of the patient. CHDs can be treated either with surgery or with an intervention. By intervention, I mean minimally invasive procedures which we do in the cath lab, such as a device closure of a hole in the heart, a balloon dilation of a blocked valve, and of course, the majority of CHDs which cannot be treated with an intervention will need a cardiac surgery, which is an open heart surgery. So there is no minimum age or weight requirement below which you cannot do a cardiac surgery. It is not that every CHD needs to be treated immediately at diagnosis. The timing of treatment depends on the symptoms of the patient and also the diagnosis. So if there is an indication for treatment, you would do it regardless of the child's weight. If we feel that the patient is stable and there is no harm in waiting, then plan the surgery at a later stage. For device closures, we do have some minimum weight requirements because when you close a defect in a child, you want to make sure that the device we are using is not causing any obstruction to the surrounding structures. But again, that varies from patient to patient. So the dictum is that in the present day and age, there is no cutoff below which you cannot treat a child. It depends from patient to patient. There are a few CHDs, like suppose you have a small hole in the heart. It is possible that if you wait, maybe within 3 to 5 years, the hole might close off on its own, what we say close spontaneously. But this is something which the pediatric cardiologist has to decide whether it is safe to wait with that CHD. Not all defects will resolve on their own. So just because someone has been diagnosed with a hole in the heart, the parent should not wait for 5 years expecting it to close. That does not happen usually. And if it's something which requires treatment and you don't treat it at the correct time, then it might be too late for the child to get treated later on. So I'll give you a common scenario. Suppose you have a child with a large VST, which is a large hole in the heart. the symptoms of this patient will be that the baby is not gaining weight, in addition to having fast breathing, poor feeding, etc. So, if the parents feel that my child is too small or too young to undergo surgery, the baby is never going to gain weight, because until you treat the defect, the symptoms will persist. So, a large VSD we would operate even if the baby is, say, 2 months of age and 2.5 kilograms of weight, because the symptoms are so severe. You cannot wait for the child to be 1 year of age and 10 kilograms of weight, because that will never happen. The baby will continue to remain quite sick. So that is the commonest example, because that is the commonest heart defect we see, a large VST. Now, there are other patients. Suppose a child has a small VST, where there are no specific symptoms. It is an incidentally picked up heart disease. The baby is growing well. The pediatric cardiologist has assessed and decided that there is no urgent indication for surgery. There you can wait and see the child every 6 months and decide when the child needs to be treated. So again, specific to the diagnosis and specific to the symptoms of the patient. So yes, that is very important, that most patients who have been operated for CHD at the correct time, they have normal lives, they have normal life expectancy, and they can lead productive, active lives with no restrictions. And this is true for about 80 to 85% of all congenital heart defects. About 10 to 15% of patients with CHD will have a major anomaly where, suppose, one side of the heart is not formed. And in these patients, we cannot completely correct the heart defect. We do a stage of surgeries known as palliative procedures. And this is done in 2 or 3 stages. And these patients do have some restrictions and some limitation to their activities and their life expectancy, but that is the rarer subset. In general, most patients with CHD will have normal lives. With the present technology available to us, we have an investigation known as a fetal echo. And this is a specific ultrasound done either by a pediatric cardiologist or by a radiologist trained in fetal medicine. And here we can detect most of the major congenital heart anomalies. Fetal echoes can pick up a heart defect as early as 15 to 16 weeks of gestation. And we routinely recommend a fetal echo between 18 to 20 weeks of gestation. And if there is a major finding, that helps us counsel the parents and decide regarding the further course of action. So the best and the commonest changes in the outcome are actually what I mentioned, which happens after birth. And if there is a critical heart disease, which we know will require surgery or an intervention soon after delivery, we often tell the parents to deliver at a cardiac center such as ours, because then you don't have the tension of having the baby get some complications during the transfer from a outside hospital. There are a rare subset of patients where we can do intrauterine procedures. These are known as balloon valvotomies if the valves are very small. But this is something which is still in experimental stages internationally, and it is not standardized protocol as of now. So fetal diagnosis in the present era is mainly to improve the planning of the postnatal treatment of these patients.